All righty, good morning, everybody. This is our last webinar of the SHIPSMP webinar series. So I appreciate all of you who've been on the webinar since we started in January. Today we are going to discuss the 2018 Medicare updates, which we do have a few numbers to share. We're also going to talk about an exciting pilot project for Part D outcomes that Tennessee is going to be a part of. So I did send out all the materials. I hope you all received those. And we'll go ahead and get started. So we do have some new prescription information. So in 2018, our new Part D deductible is going to be $405. So does anybody remember what the deductible is for 2017?
$400.
$400. So we're going up by a whopping $5. Now, when it says the donut hole, that should be 2018, not 2017. I apologize, that's a typo. But we do have new donut hole or coverage gap numbers. So the donut hole is going to be starting, think of it as the full cost of your medications. Don't worry about what the beneficiary is only paying to the pharmacy. Think of it as the full retail cost of those medications. Starts at reaches $3,750. When that happens, the beneficiary is responsible for 35% of the brand name medications and 44% of their generic medication costs. In order to get out of the donut hole, that $3,750 has to increase to $7,508.75. We are getting some feedback, so please mute your phones. That way we don't get that feedback and everyone can hear everything that we're saying. So just another reminder on that. So, okay. Now, I don't know about you guys, but the donut hole can be confusing to a lot of us. So what I like to do is look at it in a picture format. Whoever's turning the page, we can hear your feedback. Please mute your phone. Thank you. All righty. So this is who I refer to as Medicare Bob. So Medicare Bob starts with his deductible. And just so a quick reminder, all of the numbers that we're talking about today are going to be effective January 1st, 2018. So these are not numbers that are going to be effective today or tomorrow. These new numbers start the first day of 2018. So he starts with his deductible, which is that maximum of $405 that we talked about. Once he gets past his deductible, if he has one, not all drug plans have deductibles, so some people may actually skip this stage altogether. But once the person's done with their deductible, he's going to be in his initial coverage period, which is the equivalent of 25% of the cost of his medications is what he's going to be responsible for. Depending on the plan, it could be even cheaper than the 25%, but that's the standard for Medicare, drug plans, is that 25%. So he's walking along, good to go. Then, warning, warning, danger, danger. Again, the full cost of his medication reaches $3,750. When that happens, he falls into the donut hole or the coverage gap. Prior to the Affordable Care Act, he would have been paying 100% of the cost of his medications. So he's not feeling too good. Maybe he's not able to afford his medications. He may be not taking his medications as prescribed to try and not have to pay as much money out. So due to the Affordable Care Act, that is why the donut hole is closing, and he's only responsible for that 35% of his brand name medications and 44% of his generics. Now, in order to get out of the donut hole or coverage gap, like we said in the previous slide, the $3,750 has to increase to the $7,508.75. Again, we're thinking of the full cost of the medications. When that happens, he jumps back up, and he's in what's called catastrophic coverage, where he's responsible for the equivalent of about 5% of the cost of his medications. So poor Medicare Bob is going on a little drug plan roller coaster, so to speak. Any questions on that? I know the donut hole can be confusing, so if we have questions, I want to address those now while we're still talking about it. All right. So as I said, due to the Affordable Care Act, the donut hole or the coverage gap is closing. So it will be completely closed January 1st, 2020, which January 1st, 2020 is a very important date. There's three major things. Oh, no. Someone put us on mute. They're on hold. Hey, whoever just put us on hold, please end the call because we just got your ring. So if you are getting a call or need to hang up or anything like that, please hang up so we don't get that call music. So I'm going to repeat what I said because I'm not sure what you all heard before that started. The coverage gap is closing, or the donut hole is closing in January 1st, 2020, and there's three main things that are happening on January 1st, 2020 that we're going to talk about throughout this. We're getting a lot of feedback, guys. Please mute your phone. Okay, or hang up. That'll work too. So this is one of the things that's happening January 1st, 2020, and we'll talk about two more here in a minute. But you can see how it's closing. We're at 35% for brand names this year. We're going down to 30 next year, and then we'll be at that 25%, which is that initial coverage period. 44% for generics, 37% for the brand names. So if we look back a slide at Medicare Bob, rather than him going down into the donut hole, he's just going to keep going straight across the line like nothing happened. We're getting some feedback or TV in the background. Please mute your phones. We are being recorded, so please mute your phones. All righty. So also we have some new extra help copays. So the people who are receiving assistance to help pay for their medications, their copays are increasing. So they're increasing by a nickel for their generics. So in 2018, their copays for generic will be $3.35. And in 2018, the copay for their brand names is $8.35. So that's going up a dime. Not a whole lot of money to a lot of people, but those individuals who are on a limited income, that's a pretty big jump for them. So what Social Security does is in October, by the end of October, all people who qualify for extra help are going to receive an orange letter. That orange letter is going to tell them about the increase in these copays. That way they are notified, hey, starting January 1st, your extra help copays are going to increase. There's no additional correspondence that the beneficiary has to give Social Security. It's just kind of their notice that these copays are increasing a little bit. Also, we have a decrease in our Part D premium benchmark. There are two reasons why this number is important. Who can tell me one of the reasons why this benchmark is important?
If someone's being charged a late enrollment penalty.
Yes, so I heard late enrollment penalty. So whoever's turning pages, we can hear your pages turning. Please mute your phone. So the Part D late enrollment penalty is 1% for every month you were eligible but did not enroll. So let's say, for example, I have a 10% penalty because I didn't have drug coverage for 10 months. I'm going to have a $3.06 a month penalty in 2018. In 2017, our benchmark is $31.76. So this year, my penalty would be around $3.17. So my penalty is actually going down. So what is the other reason that that benchmark is so important?
If you have a zero premium plan.
Yes, so it also is going to help pay for your Medicare prescription drug plan premium. Now, the Part D premium, D is in drug. So if you have a premium plan that is $29.80 and you have a $30.62 a month stipend, your premium is going to be free, provided that that drug plan participates with extra help. Now, if you have a premium of $40, your premium is going to be $8.38. So you are going to pay the difference, or $9.38. You're going to pay the difference of that $40 minus your stipend of $30.62. So your premium will be reduced. We do not have new numbers for the income and resource guidelines for extra help or the Medicare savings programs. Those aren't released until February or March of next year. So as crazy as it sounds, for a couple months into 2018, I still want you to use the 2017 Extra Help and Medicare Savings Program numbers. And when I say Medicare Savings Program, I mean QMB, SLMB, and QI1. So still use those numbers that we have even into 2018. All right, questions on any of the new numbers or the donut hole so far? All righty. Still having some background noise, just so everybody knows. All righty, so every year I get the question of how many people are on Medicare and who's enrolled into what and how many people have an Advantage plan compared to how many people have original Medicare. Well, CMS, the Centers for Medicare and Medicaid Services, gave us that information. Again, this is on a nationwide scale, so this is not on a Tennessee level, but we are looking at nationwide numbers. So altogether, across the country, we have 57.7 million beneficiaries on Medicare. 48.7 million are on Medicare because they have aged onto Medicare. What is the magic number for Medicare when I say they've aged onto Medicare?
65.
65. Excellent. So the people who have not aged onto Medicare are on Medicare due to disability. So they are under 65, and they've either been on Social Security disability income for 24 consecutive months, or they've been diagnosed with end-stage renal disease or ALS and get their Medicare the first month of their disability. And that's the equivalent of 9 million Medicare beneficiaries. So we can see there's a lot more beneficiaries on Medicare due to aging on rather than being disabled. Thank you, baby boomers. 10,000 people per day are eligible for Medicare across the country. So how many of those people are enrolled in Original Medicare? And when I say Original Medicare, I mean the red, white, and blue Medicare card is their primary insurance that they give to the doctor in the hospital. And that's 37.7 million beneficiaries are on Original Medicare. The rest are either on a Medicare Advantage plan or some other health plan that is not Original Medicare. So it could be employer waiver programs, it could be federal employee health benefits, it could be any other kind of credible health care coverage, maybe employer benefits, all that good stuff. Now, of that 19.9 million, 18.3 million are on open market Medicare Advantage plans. Those are the plans that we look up on Plan Finder and we can enroll people into. The remaining 1.6 million are on those other plans like the employer-sponsored plans and other health plans that are available that are credible. How many people are on Part D or a prescription drug plan or any kind of prescription drug coverage, I should say, sponsored by Medicare are 42.3 million. So of the 57.7 million Medicare beneficiaries, only 42.3 million are on a Medicare-sponsored drug plan. That does not mean that the remaining, 15.4 million are all getting that Part D penalty. A majority of them have some other type of credible prescription drug coverage, maybe the VA, retiree coverage, federal employee health benefits, Indian Health Services, TRICARE, anything like that that's considered credible coverage. So don't think that we have 15+ million people having a penalty. It's a very small percentage actually accrue that Part D penalty. Any questions on this chart? All right, moving right along. We get a new Medicare card. So for those of you who haven't heard us talk about the new Medicare card, we have the new design. So that is what's showing on your screen right now. This is what people will be getting in the mail. It is still red, white, and blue, which is good. So we can still say pull out that red, white, and blue card. It has Medicare health insurance on it. It also says your name in English, and it's also translated in Spanish for the main headers, like your name, Medicare number, entitled dates. Those are all in English and Spanish. They have removed 3 components of the Medicare card that is currently, people are currently using. So they've removed Social Security numbers. Social Security numbers will no longer be your Medicare claim number. And I'm going to show you in the next slide what the Medicare claim number is going to be. It's also removed your gender. So male or female will no longer be on the card. And the last thing that was removed was the signature that the beneficiary has to sign their Medicare card. That is no longer there. One thing that has changed, and we just got an update yesterday, and I apologize, I don't have the updated card. It's actually going to say 3-1-2016, not this 3-3, because there's no one who would ever be able to get their Medicare entitled in the middle of a month. Medicare entitlement is always the first day of a month, so that has changed. Now, new Medicare cards are starting to be mailed out April 2018. It's a very important date, so if you're taking notes, I want you to write that down. April 2018 is when Medicare cards are going to start being mailed to beneficiaries. Every Medicare beneficiary should have a new card by April 2019. So there's going to be a year of getting all of our Medicare beneficiaries new cards. You can continue to use your old card with your Social Security number on it until December 31st, 2019. Starting January 1st, 2020, like I said, there's 3 main things happening on January 1st, 2020. This is the second one. January 1st, 2020, all beneficiaries have to use their new Medicare number. No claims will be able to be filed under their old Medicare number starting January 1st, 2020. So this is good for a lot of reasons. It's going to cut down on identity theft, big time, because you're not carrying around your Social Security number anymore. Also, if your Medicare card gets lost or stolen or compromised, they can regenerate you a new Medicare number. Now, as it stands, with your Medicare number being your Social Security number, they can't issue you a new Social Security number. So you your card gets flagged, and any claims they have to look into to make sure it's an actual claim. So starting when the new Medicare cards start, we could get you a new Medicare number rather than having that fraudulent Medicare number. Some bad things that are going to happen out of this, we've already gotten some scams that have started. So someone calls and says, Mr. Smith, I need your Medicare claim number to verify that we are going to send you a new Medicare card. That is a scam. Medicare already knows what your Medicare number is. So like we always say, don't give your Medicare number out to anyone that you do not know. We're also going to have some complications with people who don't update their address with Social Security. We're seeing this right now with 10-care renewal packets. Same thing is going to happen here. To where if your current address is not updated with Social Security, you won't get your new Medicare card. It's going to go to whatever address Social Security has on file for you. So let's say, for example, you have a client who's in a nursing home. Well, who gets the mail? Does the client in the nursing home continue to get their mail, or does their caregiver or power of attorney get that beneficiary's mail? You got to know, let's see, will we use that number on the Medicare website? Good question, Sharon. So starting next open enrollment, you can use the old Medicare number or the new Medicare number on the Medicare.gov Plan Finder. So you'll be able to use either number up until December 31st, 2019, and then January 1st, 2020, when you look up and do a personalized search on Medicare.gov, you're going to need the new Medicare number.
Sydney,
have their card. If the beneficiary doesn't have their card, we are encouraging everyone who does not have a Medicare card by May 1st of 2019 to start calling Social Security and asking where their card is, because they need it before January 1st, 2020. I think I had another question. Someone was talking, and I apologize.
This is Nancy. I got two questions. When people start receiving these cards in April, can they use the new cards right away?
Yes. Providers
So the providers will accept the new cards. They can automatically start billing immediately under the new number.
Yes. According to Medicare, CMS, Centers for Medicare and Medicaid Services, all providers should have their systems updated and ready to go to process claims under the new Medicare number by April 1st, 2018, when the cards start getting mailed out.
Okay. Are the cards going to be paper like they are now, or will they be more plastic like a lot of the Advantage Plan and drug plan ID cards are? Do you know?
They are still going to be the flimsy paper just like they are currently.
Okay.
Good question. Any other questions? Oh, something else to note is we don't know the rhyme or reason that these cards are going to be mailed out. So it's going to be kind of a random system. So let's say Jerry and I were husband and wife. Jerry might get his card June 2018. I might not get mine until December 2018. It doesn't matter if you're husband or wife. It doesn't matter if you're neighbors, if you're sisters, brothers, whatever. You may get your cards at a different time. And the reason for this is to make sure that people aren't on the lookout and know when your Medicare card's coming. So let's say they're not doing this, but let's say as an example, Medicare released that everyone in the zip code of 37076 will be getting their new Medicare cards in April 2018. Well, all those scammers are going to go to that zip code and look in all the mailboxes and try and get the new Medicare numbers, new Medicare cards that could be in their mailbox. So that's why they're doing this random system, and they're not going to let us know what rhyme or reason they're doing it, which I think is very smart. So between April 1st, 2018 and April 30th, 2019, tell beneficiaries to be on the lookout for that new Medicare card. I'm trying to think if there's anything else I need to mention, and I might think of some other things. But anybody have any questions on that? Looking at the next slide is how the new Medicare number is going to be formulated. So it's an 11-digit code is kind of what I like to call it. You can see it's going to be a number, letter, letter, number, letter, letter, number, letter, letter, number, number. So there's going to be a lot of wacky combinations out there. But this makes it even, it's going to make it complicated to memorize. So I don't expect our Medicare beneficiaries to memorize this number. But it will also be safe for them to carry it around in their wallet when they need it, because it's not their Social Security number. So they call it the Medicare Beneficiary Identifier, but we're just calling it the new Medicare number for our beneficiaries. It's a lot easier for them to understand than Medicare Beneficiary Identifier. All right. Questions on the Medicare card before we move on to supplemental plans? All right. Will all this information be included in the new card? Probably not. I'm not sure what information they're going to be to put together with the new Medicare card. I don't know if they'll say it's okay to carry. What they have told us, what CMS said was once you get your new Medicare card, destroy your old Medicare card. I'm hesitant to tell beneficiaries that. I would like them to keep their old card in case something happens and something gets confused at the provider. I would say destroy your old Medicare card January 1st, 2020, when it can no longer be used. Up until then, you can use both of your cards and make sure that your claims are processed. But Medicare is saying the minute you get that new card, destroy your old card. And destroy doesn't mean throw away in the trash. Destroy means shred, burn, make sure that no one can read that card, destroy it. Good question. Any other questions before we move on? All right. So Medicare supplemental plans. We've been talking about this for a couple years, but we always want to make sure everyone remembers because this is an update. Just re-jog your memory. Starting January 1st, 2020, so this is our third thing, the last of the three that are happening January 1st, 2020. Plan C as in cat and F as in Frank for your Medicare supplemental plans will no longer be sold, meaning no new people who on their red, white, and blue Medicare card have January 1st, 2020, effective for their Medicare Part B, will be able to purchase Plan C or Plan F. Now, those people currently enrolled will be able to stay enrolled if they want to and continue to have their benefits same as normal. But new beneficiaries will not be able to purchase that Plan F or that Plan C. So for those of you who are saying Plan F and Plan C, what the heck does that mean? Here is our supplemental plan chart. So you can see Plan C, as in cat, covers everything but the Part B excess charge, and Plan G, as in girl, covers everything but the Part B deductible, which is $183. The unique thing about Plan C and Plan F is they both pay, oh, I'm sorry, I said that wrong. Plan F pays for everything. Plan C pays for everything except the excess charge. I apologize. So the unique thing about Plan C and Plan F are that they both pay that Part B as in boy deductible. So that's the reason those two plans are going away. The two next most comprehensive plans would be Plan G as in girl and Plan D as in dog. So I always get the question, well, right now, since we know this, do we tell people to enroll into Plan F or Plan C? What I do is I tell them that it's going away. Because remember, we're non-biased. We can't tell people, no, Plan F is terrible. You can't enroll into Plan F. But what I explain to them is Plan C and Plan F will no longer be sold as of January 1st, 2020. And it's possible that since no new people are going to enroll into those plans, you may see a premium increase at a higher rate, since the only people who are paying for the health care are people who are currently enrolled in those plans. Plan G and Plan D would be the next best options to consider. If they still say, Sydney, I want Plan F, all right, I'm going to do a comparison for your Plan F. Now, we have not been told if there's going to be, if there's a cap on raising premiums. To my knowledge, there is no cap on raising premiums. What the insurance companies do is they put in a request to our Department of Commerce and Insurance and say we need to increase our premiums by X amount, and the Department of Commerce and Insurance either approves or denies those premium increases. So I don't, in my research, I have not seen a cap on any of those. So I asked CMS when we were in Arlington, Texas, that if someone is currently enrolled in Plan C and Plan F, are they going to get a guaranteed issue period to drop their Plan C or Plan F and enroll into a different plan since their plan is no longer going to be sold? And they were not able to give me an answer. They said it's not happening until 2020, so the work group who's coming up with the policies hasn't gotten to that part of the policy yet. So hopefully here soon we will be able to know if a guaranteed issue right will be available for people who are currently in Plan C or Plan F. But we don't have confirmation on that yet.
This is Nancy, and also in the 2016 Medicare booklet on the Medigap plans, for instance, if someone is over 65 and going from group health onto Medicare, and it says they can get Medigap plan A, B, C, F, K, or L with a guaranteed issue right. Mm-hmm. Are the C and the F in that place is going to be replaced by D and G? Do you know?
We have not got, we don't know. We haven't been told that either. But that's a good question that I'm going to write down to ask our CMS contact if they know or have any information.
Because if they aren't, I mean, that's leaving the people in that group with not a lot to choose from.
Right.
I mean, they've either got the deductibles and the co-pays and stuff, or they've got no nursing facility coverage.
Right.
So, Okay, thank
I
you.
agree. I will definitely add that to my list.
Okay.
Great question. Any other questions? Because this is the last slide on the update. So any questions on any of the updates that we've covered? All right. So I'm going to switch gears. And we are going to talk about an exciting pilot project that Tennessee is a part of. As soon as the computer loads. It's like open enrollment when Claim Finder freezes. Get your small talk going. All right, here we go. From the beginning. All righty. So Tennessee is included along with, I believe, 9 other states. So we have 10-state pilot projects to record Part D outcomes. What we referred to these as last year were our Part D savings. So last year during open enrollment, Tennessee, on our own, we kind of had our own formula for how we were doing these things. We had a big spreadsheet that we asked people to fill out, that we were tracking our Part D savings during open enrollment, meaning when someone came to you during open enrollment, they were enrolled into Plan A, and you looked them up in the Plan Finder and found a plan cheaper and enrolled them into Plan B, and then you calculated the savings that you had for that beneficiary. Now we're going to start doing that as a pilot across the country. Now, the 10 states, I can't remember who they are off the top of my head, but we have states from the south, the north, east, west, the plains, all over the country. So we're not focusing in one area. We have states from all over the country. And what the main purpose of this is to show how our direct service is working and is conducted. So as many of you know, SHIPS funding has been in jeopardy here this year. So one of the ways that we want to show kind of, in a way, the value, but not, I don't want you to think that these savings are the only thing that SHIP does and it's the most important thing that SHIP does, because it's not. But we want to put some figures to our direct service work. And one of the ways we're going to do that is to show our elected officials how much money we can save beneficiaries throughout the year. So nationally, SHIP is funded at $47.1 million. So our hope is, through the savings project, that we can show them that, hey, we're saving people at least that much money, so we're actually paying for our own program. Keep us around. We're doing really good work. We also want to make sure that our data is auditable. And when I say auditable, which is a really hard word to say, that means we can prove without a shadow of a doubt that we have saved this person this amount of money. And I'm going to show you how we're going to do that here in a little bit. But our goal is not a high dollar savings, because the outcomes, which is why we're not calling it savings anymore, is really going to be outcomes, because we have no control if we're able to save somebody money or not. The biggest factor is how the drug plans change every year, which, again, we have no control over. So let's say, for an example, and this will never happen, but bear with me for my example. Let's say every single drug plan this year decides to change nothing and everything's the exact same in 2018. Well, we're not going to have any savings. Again, that's never going to happen, but that's why we're not looking at the dollar amount. So during open enrollment last year, Tennessee saved the beneficiaries $3.5 million, which is amazing in a 45-day period. But by no means do we want that to be a benchmark, that, oh, we got to hit that $3.5 million again. Well, what if we hit $3 million? It's not our fault if a drug plan didn't change as much and we weren't able to save people that much money, because their plan is still the best plan. So please don't focus on the dollar amount. That might have been confusing, but does everyone understand kind of why we're not focusing on trying to get high dollars? With the silence, I'm going to say yes. Okay. So what we're doing is we are looking on the client contact form, and the big thing that we are looking at to mark is box 4 and box 30, and I'm going to show you exactly what those look like here in a minute. But I'm going to show you now. So box number 4 means that you enrolled someone into a prescription drug plan, standalone drug plan with original Medicare. Marking number 30 means that you completed an enrollment for a Medicare Advantage plan. And when I say the word enrollment, I mean you have physically gone on the Medicare.gov plan finder, physically clicked that enrollment button, completed the application, and have an enrollment confirmation that that person was enrolled into whatever drug plan they decided. That counts as an enrollment. If you only do a plan comparison and say, here are your results, call me if you want to enroll, you have not enrolled anyone. We don't need to know those numbers. We need to know if you've clicked that enrollment button. So mark number 4 or number 30. Does that make sense? Tell me if we have any questions so far. I'm going to go through this kind of slow. Some of you have already heard this spiel, and I apologize that you're hearing it again. Does everybody understand what the definition of a plan enrollment is? You're clicking that enrollment button. All right. New in our database and new on our client contact forms, we have updated them. If you don't have an updated client contact form, please let your coordinator know that you need one, because we've added a few of these special use fields to the new client contact form. So what we need is a little bit more work from the staff and volunteers to record our savings. And what we need, and I'm going to show you an example of this, so bear with me now, and I'm going to give you an example that'll make sense. So what we need is the before amount of that drug plan and the after amount. And when I say the before amount, I mean someone comes to you during open enrollment and they're enrolled into an AARP plan. That's the current plan. That's the before plan. The after plan is whatever plan you enroll them into. Whatever plan you physically click that enrollment button and complete that enrollment application and get that confirmation. That is the after amount. The drug ID list and password date, those are not required. You don't have to write that in. That's actually not going to be on the client contact form that we've updated. And there's also a note section that we're going to go over here in a minute on what exactly that note section means. So starting October 1st, 2017, the before number and the after number are going to be required to submit a client contact. So let me explain the entire process. What's going to happen is you're going to mark either number 4 or number 30. Whichever one you mark, you're then going to put your before amount in, then your after amount in, and you'll be able to submit that client contact. If you mark number 4 or number 30 and do not have these values in, you will have an error and your client contact will not be submitted. So I know many volunteers do not enter data into our database. A lot of you send in your client contact forms, and then we either have a staff person or a volunteer that enters your data. It's very, very important when you submit that paperwork to your volunteer coordinator and you enrolled someone, we need to know those numbers of the before plan and the after plan. Starting again, October 1st, 2017. The note section will still be there, but it's not required. So before I move on, who's got questions on that? And like I said, I'm going to do an example to hopefully make it a little bit clearer, but if we have any questions now, I want to address them. Okay, so moving right along. This is basically what I already said. This is the before and after fields. You do not have to do any calculation. You don't have to put in the savings. So if you have a savings of $500, you don't do any math. I'm not going to make you do addition, subtraction, multiplication, or division. You just enter those numbers, and our contractor that does our database, Technical Frontiers, will do all the calculations that are needed. We did have a question at one of the volunteer update trainings in the South Central region, and I found an answer. We talked about comparing pharmacies, so which pharmacy the beneficiary wants. So we know when we do counseling and we're on the plan finder, we ask the beneficiary, what pharmacy do you go to or do you want to go to? And we can add up to 2 pharmacies into that database. So let's see, we do Walgreens and CVS. And the beneficiary says, I go to Walgreens, but just for fun, let's see what CVS has to offer. Again, Walgreens is their preferred pharmacy right now. That's the one that they go to. We do a comparison, and it turns out that CVS, if they change their pharmacy, would save them $1,000. Well, then our before cost would be the Walgreens in their current plan. The after cost would be the CVS of the new plan because the beneficiary has decided they're going to change pharmacies. It is not the counselor's decision that they're changing pharmacy. It is the beneficiary has told me they are going to change to CVS to save money. If the beneficiary says, nah, I'm still going to go to Walgreens, and even though it's $1,000 more expensive, I'm still going to go to Walgreens, then we can compare Walgreens to Walgreens. Does that make sense? I know that can be confusing, so if you have questions, please ask. Trust me, with this pilot project, there is no dumb question. Whatever you are thinking, someone else is thinking and may just be shy to ask. All righty. So hopefully the people who were with South Central when I was at your training on Monday and we had the conversation, hopefully that makes more sense. If not, and you don't want to ask a question on the webinar, feel free to get in touch with Sherry or email me directly, and I can clarify anything that you need. So here's our example. So I'm going to say, Nancy, I'm using you as an example. Nancy comes to me during open enrollment, and I type in all of her medications, and for the sake of this example, we're going to say this is all 2018 data. It's not, but bear with me for this example. She comes to me, and she is enrolled in the AARP Medicare RX Preferred PDP plan, this plan right here. Her current cost when she comes to me, because she likes to go to CVS, is $1,261.80. That is what she's currently enrolled into and the pharmacy that she says she wants to go to. That is what I am putting in my before money special use field. I do her comparison and I say, hey, Nancy, I have great news. I could save you almost $500 next year if you want to enroll into the WellCare Classic prescription drug plan. Your cost would go down to $783.10. Again, notice how I told Nancy if you want to enroll. Yes, we can save money, but it's up to Nancy, the beneficiary, to say, yes, I want to enroll. We can't tell them that this is the best option. But Nancy says, of course I want to save that much money. So what do? I physically click that enrollment button. I ask Nancy all the questions that I need to fill out that enrollment application. I get my enrollment confirmation, and now I have my savings. So I have my before number, and I have my after number. Does that help clarify what we're doing? Does anyone have any questions on that example or why those numbers were placed?
Just to clarify, if someone is new to Medicare and so there's no prior plan, just use the number that comes up in the original, for the original Medicare?
Yes. So we do have a lot of beneficiaries, and that's where I'm actually going to transition out of the presentation, and we are going to look at the notes section and kind of what scenarios could happen that we want to track those savings. So I'm going to pull up another file. So that was a great segue, Nancy. Thank you. But yes, we have a lot of beneficiaries, especially right now during the non-open enrollment season, that are on Medicare because they're new. They've retired or they've never had insurance before or anything like that. So here is what we would put into those notes fields. Now this is completely optional. As a volunteer, you are not required to fill out the notes section. You don't have to if you don't want to. However, again, it is going to be required for that before number and that after number. The notes section, what we're about to discuss, is the only thing that is optional. You don't have to do it if you don't want to. So what Nancy mentioned is actually scenario number 1. New to Medicare regardless of previous coverage. So when that happens, what we do in Plan Finder is we do a personalized search. And what happens when we click to compare plans is that the first plan that comes up is your current plan. Someone who's not on Medicare, their current plan is original Medicare, meaning they have no drug coverage. So that's the number that we are going to put as their before number. Whatever plan we enroll them into is going to be the after number. There are some of these that be honest, I'm never going to use because they kind of sound like the same thing. But I'm going to go over all of these scenarios, and then I'll let you know which ones I personally will use and which ones I won't. And again, like I said, let me ask the group this question. Is this required for you all to fill out? Yes or no?
You said no.
No. I just want to make sure the only way I know you all are understanding is if I ask the question and you give me the answer back. So again, no, you are not required to use these notes if you don't want to. If you learn nothing else from this webinar, I hope you take that away. So the second kind of note that you can write in is if there's a plan termination or non-renewal. So this is new information that we just got today. So you might want to write this down. Blue Cross Blue Shield HMO plans, so their Blue Choice plan, is no longer going to be offered in 2018. Again, only the HMO plan. So your Garnet, your Ruby, your Diamond, that's still going to be around. But the Blue Care Choice HMO plan is no longer going to be available as of 2018. So that is considered a non-renewed plan. So you might have to put a number 2 there if you change someone out of that plan.
Sydney?
Yes.
Are they going to, does that include the Blue Care Special Needs Plan?
We don't know. We were told the Blue Choice HMO plan. We weren't told about any special needs plan. We're getting clarification on that, but from what our contact at Blue Cross Blue Shield said, it's just the only HMO plan. But I will get clarification on that for you. All righty, another one that I'm definitely going to use that we see a lot in non-open enrollment time are people who are new to the service area. So people who are moving to Tennessee, we're getting a lot of those. I'm one of those. I'm a transplant from Indiana. So we have a beneficiary who's moving to Tennessee from Mississippi, wherever, I guess I should say, it doesn't really matter. They're new to the plan service area. We look at the plan that they're currently enrolled into. That's their before plan. The after plan is what we enroll them into. So I'll definitely be using number 1 and number 3. I will also be using number 4 a lot, I have a feeling. So we know the people who qualify for extra help or LIS get a continuous special enrollment period. So anyone that comes to me and says, I have LIS, I'm going to compare their plan just to make sure they're in the best one. So if I find someone with LIS and I change them to a cheaper plan, again, the plan they come to me with is the before plan. What I enroll them into is the after plan. Number 5 and 6 and 7 are kind of the exact same thing as number 4, just with a little bit more detail. So LIS and will owe a premium. Remember we talked a little bit earlier that our benchmark is $30.62. If you have a $40 a month premium, you're going to pay that difference. So your drug plan actually does have a premium, but it's reduced. That's kind of what number 5 is saying. Again, same thing as receiving extra help in my opinion. LIS automatic enrollment. There are some beneficiaries who are automatically enrolled into a drug plan by Medicare because they receive LIS but don't have a drug plan. So we may change them to a different plan. Again, kind of the same thing as number 4. And then number 7 is lost or changed their LIS MSP subsidy. So we review their plan. Again, kind of the same thing. Number 8 is a drug formulary change. So if someone's medication is no longer covered and they have a special enrollment period or they're able to switch because of that drug formulary change. Number 9, restriction changes, so prior authorization, step therapy, or quantity limits. Again, people who just have a new drug on their plan or new drug restrictions does not automatically give them the right or the ability to change their drug plan. So they have to have some kind of special circumstance to where they can change those. Number 10 is like what we just talked about, a pharmacy network change. So they go from CVS to Walgreens or vice versa, or whatever plan pharmacy they really like, they decide, I'm going to save money and go to a different one. Beneficiary prescription changes. Again, you're going to have a special circumstance for that. Special needs plan enrollment assistance. In Tennessee, we are not able to enroll people into a special needs plan. So that's not going to apply to us. We can tell them a special needs plan is available, but we will never be able to click that enrollment button to enroll them. Dual demonstration enrollment, you can see that it only applies to 3 states, and we are not one of them. So we are not going to be using number 13. And then number 14, other changes not described. So again, the ones I'm personally going to be using the most, and again, not required by you. Me, I'm using them because I'm obsessive compulsive and I always have to write notes, is number 1, number 3, and number 4 are going to be the big ones that I use. Possibly a couple other ones every now and then, but those are the main 3. One that they don't have that I wish they would have included is one that says open enrollment or annual election period, because a majority of the people between October 15th and December 7th that we're going to be changing is because it's open enrollment and they can. So we're able to type in some notes that aren't just letters. So what I'll probably end up doing is just typing AEP or OEP in the notes section so I know I changed that person during open enrollment. So those are our notes fields that we can use, again, if you want to, not a requirement. And those are some of the situations to where we'll use this pilot project. Questions on those? Okay. Excellent. All right, going back to our PowerPoint here. So how are we going to verify that we did this? How are we going to verify if, let's say, for example, my elected official comes to the office and says, Sydney, you told me that you enrolled Nancy Parker into a plan that saved her $500. Yes, sir. Yes, ma'am, I did. And he or she tells me to prove it. I'm going to have documentation that I enrolled Nancy into this plan. Again, Nancy, I'm just using you as an example. Nancy can definitely enroll herself into her own plan. So some methods, you don't have to use all of these, but some methods that I'm going to use and I think that are good to use are hard copies of the before plan, the after plan, and the enrollment confirmation. So having hard copy physical proof. Now that's easy for me and the staff to do because we have access to printers and copiers and ink and all of that. So some of you who don't have that option, you may want to do a screenshot and maybe on your computer have a file that says Nancy Parker before or after enrollment and have it electronically. The client's drug ID list and password, I don't know how that's actually going to be confirmation that you enrolled someone into a plan because all that does is pull up a drug list. It doesn't say anything about enrollment. And something else is just another electronic file like I mentioned. The big thing, the biggest thing that we need to verify that we enrolled someone is that confirmation, the enrollment confirmation that you get after the application has been completed. So if you can't print it off, minimally, please write down the confirmation number. That way we have proof that we have confirmation that we enrolled someone into a different plan.
Sydney?
Yes.
If we don't, I understand the confirmation, but the confirmation only says you enrolled somebody. It doesn't say what you saved them. So
right.
If you don't have the comparison, then how are you going to prove that you saved them money?
That's a good question, and I don't have an answer for that. I'm just trying to help the volunteers who don't have access to things that they can do hard copy or electronically, at least get something on file that we enrolled someone into a new plan. And what we could do is
prefer that.
Right, I would prefer a hard copy. Yes, I'd prefer a hard copy or electronic copy of the plan finder comparisons and the enrollment confirmation. That would be ideal.
Yeah. Okay.
But not all volunteers are able to do that scenario, and we completely understand that. This pilot project is asking for more work than the already amazing work that the volunteers do. So whatever is going to be easiest at this point right now, we will accept. The next slides are the circumstances that we just talked about when we looked at numbers 0 through 14. So I'm going to skip past these slides. It's the new plan, new to Medicare, changing plans, and the low-income subsidy people. So I'm skipping the next 3 slides. I need to delete them from the presentation altogether. But the last thing I want to talk to you about is what not to report, things that we do not need to know for this pilot project. The big thing is if you just do a comparison and there's no enrollment, we don't need to know about it because that was not an outcome. That's a potential outcome, but we need that beneficiary to think about it and let us know they want to change to a different plan, again, so we can click that enrollment button. Also, switching to another pharmacy, that's actually one of the examples that they gave us, so I think that's null and void now, so don't worry about the second bullet. The last one, though, is important that if we just do an extra help or Medicare Savings Program application, we're not recording the savings for that with just doing the application. So when I say just doing the application, it means they haven't been approved for benefits yet. Once they've been approved for benefits and we do a comparison to save them money, then yes, we're going to record that. But just the application itself, we're not recording for this pilot project. And that's my spiel on the pilot. Who has questions? I know this is more of a complex topic. Or if you don't want to talk about it on the webinar and you just want to email me, I'm happy to talk. You guys know me, I talk all day long about everything. Yep. All right. Does anyone have any questions about anything that we've discussed today on the webinar? Anything at all?
I have one, and it's just a confirmation because it wasn't brought up, so that sort of answers my question.
Okay.
We have not talked about the Part A or the Part B deductible or the Part B premium. So what that's telling me is those are all remaining the same for 2018.
No. What that means is those numbers have not been released yet.
Okay.
So the Part A and Part B premium, deductibles, copays, everything that Nancy just mentioned, those aren't released until around mid-November. So there is a possibility that those numbers will change. We just haven't been notified yet. Once we get the numbers, we will be sure to send that to the coordinators to send out to you all. Excellent question. Now I'm looking at our chats to make sure I didn't miss any questions. There might have been. Don't have sound. Sorry about that. Sharon made a comment. Early in the Part D program, there was talk of waiving the penalty for young disabled. Has that ever been brought up again? No, to my knowledge, it has not. So no matter why you're on Medicare, if you do not enroll into a drug plan when you are first eligible and you don't have any credible coverage, it's my understanding that a penalty will apply. You can always appeal a penalty. We appeal everything that we don't like. So appeal, appeal, appeal. Remember, I already answered that. Answered that. All right, I think I answered all the questions in the chat. Last call for questions before I stop the recording. Sorry, I'm trying to figure out how to stop the recording. All right, I'm going to stop the recording. Thank you all so much again for being on the webinar with us today. I will be posting the webinar to our YouTube channel latest on Monday, earliest by the end of the day today, depending on how long it takes the WebEx to generate the webinar. So I'm going to stop the webinar now.